Hello friends, in this video I will be talking about terrible triad injuries. So the presentation will be discussing what the terrible triad injury is, what are its components and how do we diagnose it, and what should be our plan of action and what should be the rehabilitation. So what is terrible triad? So what you are seeing in these presentations are multiple radiographs. One is lateral view, one is anteroposterior view, another one is also an anteroposterior view. So you see in lateral view there is posterior elbow dislocation. Why? Because the olecranon articular surface is not articulating with the trochlea. It should have been articulating here if it was normal. And also you can see there is some fractured fragments lying here, some fractured fragments lying here, and definitely the proximal part of radius. You see this is the radial proximal diaphysis, this is the radial neck, and this should have been a smooth radial head disc, but it's not there. That means this fragment which is broken is likely to be a fracture of radial head. And in this view, this is an anteroposterior view, the whole of the proximal forearm is dislocated laterally. So therefore the dislocation is posterolateral. And on this x-ray you can see all these things are there. The radial head is fractured, there is some fracture lying here, the proximal part of radius is not normal, but the dislocation here is the posteromedial. So what is terrible triad injury? Terrible triad injury is a complex injury pattern. That's why it is called terrible, because it is having very challenging management and also the outcomes are very unpredictable. That's why it's terrible. So it has component of radial head fracture and posterolateral instability. Sometimes there is coronoid fracture also. In rare scenarios, there may be disruption of the medial ligamentous structures also. In such scenario, the elbow will be grossly unstable and the migration of the proximal forearm can be either lateral or it can be medial also. That means this injury will also count as terrible triad injury. So starting with the mechanism of terrible triad injury. So this is the elbow position when seen from front in a normal scenario, and this is the position of elbow when seen from sides in a normal scenario. In terrible triad injury, there is axial stress on the elbow joint in extension, and along with the axial stress there is a rotational component of external rotation, or you can call it supination. Because of the axial stress there are stresses over the radial head, so there will be possibility of the radial head fracture because of this axial stress. Then there comes the component of rotational stress also. That means after radial head fracture the radial head will migrate posteriorly as well as laterally, and there will be disruption of the ligaments lying on the lateral surface of the elbow joint. So here there will be failure. So the radial head will get fractured, then lie posterolaterally. And what happens when the axial stress still continues? There will be stress on the coronoid process, the tip of the coronoid. Continued axial stress will result in failure somewhere here, resulting in coronoid fracture. Now automatically the elbow will become grossly unstable in posterolateral direction. It will migrate laterally, and it will migrate posteriorly also. Therefore there will be posterolateral dislocation, which is governed by the two mechanisms, the axial stress in extension and the external rotation stress again in extension. Now if the external rotation stress continues, there will be stress on the medial structures also. So ultimately the medial ligaments can also fail, but be aware that the medial ligaments are the strongest one in the elbow joint. Just a quick review of the ligamentous structures around the elbow joint which are affected in terrible triad injury. So you see this is the lateral side of the elbow joint. You see there is lateral epicondyle, which is the originating point of the lateral ligamentous complex. You see these fanning fibers which are getting attached in the proximal part of the radius via a round capsular condensation. This condensation is nothing but annular ligament. Annular ligament helps in covering the radial head while it is rotating in supination and pronation. It is round. It inserts on either side of the radial notch of the proximal ulna. So the radial head is seated in the radial notch, and on either side of this notch is the annular ligament which covers the radial head. So this ligament, lateral radial collateral ligament, it starts on the lateral epicondyle and inserts over the annular ligament and indirectly provides stability to the radiocapitular joint. This is lateral ulnar collateral ligament. It provides the lateral stability to the ulnohumeral joint. Anconius will be somewhere here, and on the anterior part of this ligament will be common extensor origin muscles. So you see this figure, this is a clean case without any terrible triad injury, and we have approached the radiocapitular joint using standard Kaplan approach. So the interval of the Kaplan approach is between the common extensor origin and the anconeus muscle. So you see these fibers, longitudinal oblique fibers, they are actually the fibers of lateral ulnar collateral ligament. They start from the lateral epicondyle and inserts over the supinator crest somewhere here on the proximal part of the ulna and on the lateral side. And beneath this is the anconeus. So this is an example of terrible triad injury in which you see the origin of the lateral ulnar collateral ligament as well as lateral radiocapsular ligament is torn. You see there's smooth bone, then suddenly there is dip in this smooth bone, or you can say some irregularity is there because the lateral ligamentous complex has been avulsed. You see there are some frayed fibers of the ligamentous complex here, and this round structure is nothing but the annular ligament. So these are the fibers of the lateral radial collateral ligament, and these are the fibers of the lateral ulnar collateral ligament which is torn, and this is the area where it should have been inserted, but it is lying somewhere here after getting torn. You can also see there is a radial head fracture also. You see there is a step here. Now coming to the medial side. On the medial side there are three important ligaments, one of which is the strongest one while two are relatively weaker ligaments. The anterior medial collateral ligament is the strongest one. It starts somewhere between the medial epicondyle and medial aspect of the trochlea and inserts over the sublime tubercle of the coronoid process. This is coronoid process, this is sublime tubercle. And then there is posterior medial collateral ligament which starts inferior to the medial epicondyle, again on the outer aspect of the trochlea, and the transverse ligament is nothing but a capsular condensation, and it actually provides attachment to the muscles originating from the proximal ulna and has little contribution to the ulnohumeral joint stability. In this figure you see the anterior part, that is anterior medial collateral ligament, can be seen here. These are the fibers of anterior medial collateral ligament inserting over the coronoid process medial side, that is sublime tubercle. And this part, the part which is tied with the sutures, tagged with the sutures, is the transverse ligament which has been reflected from this part to visualize the joint. It has to be repaired, and this part you see, this is the triceps which is inserting over the olecranon, and you see this is the ulnar nerve which is protected with a feeding tube. Now order of failure in terrible triad injuries. So by this time it should have been clear that the first thing that fails is the radial head fracture, but be aware in some scenarios you might not find radial head fracture because before the bony failure occurs the elbow would have been already dislocated in posterolateral direction, but the radial head fracture might not be there. Then there will be failure of lateral ulnar collateral ligament complex. To some extent the radial component may also be injured, but definitely there will be injury to the lateral ulnar collateral ligament because elbow dislocates only after there will be failure of LUCL. Then there can be fracture of coronoid process also. Again, it's not necessary that it will always be fracture. Sometimes because of the anterior capsular tear and the tear near the insertion of brachialis, there might be soft tissue failure rather than coronoid tip fracture. So there will be failure but not in the coronoid process. So there can be anterior capsular or brachialis insertion injury. And last thing that is injured is the medial collateral ligament complex, but again it is very uncommon. So diagnosis is based on clinical findings. In clinical findings you'll see the dislocated elbow, gross swelling of the elbow joint, there will be crepitus if there are associated fractures. So all those findings which are there in elbow dislocation and fracture around the elbow. And the diagnosis is usually confirmed by the radiographs, and CT is required for planning the surgery because CT will tell you about the fracture fragments, their exact position, the amount of combination. If the radial head fracture is very comminuted, then you will need to replace it. If it is reconstructible, there are 3-4 fragments, then you can definitely reconstruct it and fix with a plate. And it will also tell you about the size of the coronoid fragment. See, if the size of the coronoid fragment is less than 25%, then you'll need to treat it as an avulsion. If it's more than 25%, then you'll need to fix it with some screw or plate fixation. The role of MRI is very doubtful because in acute injuries the MRI will not be able to tell you exact injury because of the extensive edema around the elbow joint. It all depends upon your instability pattern, and you'll have to repair the ligaments according to the site of injury that you'll visualize upon surgical exposure. Now let's come to the surgical tips. So the standard approach for the terrible triad injury is Coccus approach, but if you want more anterior dissection then you can use Kaplan approach also. The Coccus approach uses the interval between the anconeus and the common extensor origin that we had seen in the previous picture. So the incision starts from palpable area of the lateral epicondyle towards the proximal part of ulna and it will be centered over the radial head. By doing supination pronation movements, you can roughly locate the location of the proximal part of the radius. So the incision will be centered over the radial head, or you can say radiocapsular joint. If you want slightly more exposure medially, then you can either extend the incision proximally to release the muscles originating near the lateral supracondylar ridge. In terrible triad injury, you have to proceed with a blunt dissection. Why? Because by blunt dissection, you will be able to locate the void of the ligamentous failure. You need not to create any plane, just find where is the void. And the best way to find the void is to look for any bony fragments palpable near the dissection plane. And the moment you feel any bony fragment, there should be some site of void because of the ligamentous failure. For example, you see, we have just bluntly dissected this region and we found that a fractured fragment is lying here, which is nothing but the fractured fragment of the radial head. Further, blunt dissection results in better visualization of the fractured fragments. You see, now we are able to see the lateral epicondyle region and the fractured part of the radial head. Again, going bluntly along with the injury plane, will be able to visualize whole of the radiocapsular joint. Now, as we know, this is posterolateral dislocation. We'll be able to see the remaining part of the radial head, and this part you are seeing is nothing but the olecranon. This is the articulation between the radial head and the proximal ulna, and this is the olecranon. You see white shiny articular cartilage of olecranon. Why it is lying here laterally? Because of the posterolateral dislocation. Now, if you reduce the dislocation manually, then you will be able to see the lateral condyle. You see, we have reduced the radial head to the capitulum, and this is lateral condyle, and the part of the lateral collateral ligament complex which should have been originating somewhere here is missing because of the injury. And it is very important to visualize the olecranon in the dislocated position. Why? Because you will be able to see the fracture of the coronoid. So olecranon will be lying somewhere here, and this is the part of coronoid which is actually fractured. So the olecranon will be intact, the coronoid will be fractured. What you need to do, keep the elbow dislocated in that position. Now drill 2 holes towards the site of fracture of the coronoid. Then pass 2 suture strands through these holes so that you will be able to pull any suture through this hole back here. We'll see this in coming example. Once that step is done, now return to the radiocapsular joint. Reduce the radiocapsular joint and then create a plane anterior to the capitulum and trochlea. Then you will be able to palpate the bony fragments of the fractured coronoid. If the fracture fragment is large, that is more than 25%, that needs fixation. But if it is comminuted small fragments less than 25%, the coronoid, it should be treated like an avulsion. That means we have to pass some sutures through the avulsed part of the coronoid and repair it to the remaining part of the coronoid. So you'll be able to locate the fractured fragments of the coronoid. Now hold those fragments, pull laterally, then you will be able to visualize the brachialis insertion over it and the anterior capsule which is also inserting over that part. Now take multiple bites on the brachialis insertion and the capsule, anterior capsule which is inserting on the coronoid tip. Once that is done, then bring those sutures through the holes we have created. At this stage, do not tie it. You have to wait for the radial head reconstruction and relocation of elbow in correct position. Only then you can tie it properly, because only then it will be in maximum tension so that the elbow will remain stable. So once that step is done, that you have passed the sutures through the drill hole that you have created in the proximal ulna, then you have to reconstruct the radial head. I'll not be going towards the radial head reconstruction steps in this video because there's a separate lecture on that. Only thing that you need to remember is to keep the implant in the safe zone. The safe zone is 90 degree to 110 degree dorsal to the plane of radial styloid. So suppose if the position of the forearm is in mid-prone position, starting from the plane of the radial styloid, 90 degree dorsal is the safe plane. So you have to be 90 degree away from the plane of radial styloid. Now once you have reconstructed the radial head perfectly or replaced it if it was not reconstructible, then you have to tie this suture so that the coronoid will regain its normal position. And even if it is not anatomically reduced, the tension in the anterior capsule and the brachialis insertion will be adequate to keep the elbow joint stable. But remember, you have to tie it only after radial head reconstruction, not before that. Otherwise, you'll not be able to relocate the radial head properly. Once you have stabilized the elbow after reconstructing the radial head and passing the sutures through the coronoid, then you have to address the lateral structures. So you have restored the posterior stability to some extent. The lateral instability, however, still persists, and then it has to be corrected using a suture anchor over the lateral epicondyle. If you are not sure where to put suture anchor, just imagine that the capitulum is a round circle and radial head moves in a circular position like this. Your suture anchor should lie somewhere near the center of this circle. So the best way is to locate the site where you are not able to visualize the normal smooth margin of the lateral epicondyle. Like you see, there's smooth bone, but there's certain dip in the bone here because of the avulsion of the lateral ligamentous complex. You can put the suture anchor in that position, and once you have put the suture anchor, then you have to keep the elbow in mid flexion position and repair the lateral collateral ligament to this position, and then reinforce the anterior part, that is the lateral radial collateral ligament, to this attachment. So you have to repair both the components, lateral ulnar collateral ligament as well as lateral radial collateral ligament. Even after we have done the repair, we can use these fibers to reinforce the repair. That means we can use multiple knots between the lateral ulnar collateral ligament band and the lateral radial collateral ligament band, and also tie those with the common extensor origin. Now once you have done all this thing, then you have to check the C-arm and put a valgus stress. If the medial side is opening, that means the medial collateral ligament is injured. Then you have to give a separate incision on the medial side and repair those ligaments. But I've told you, it is very uncommon. Post-operatively, early motion has to be started, otherwise it will result in stiff elbow. However, the motion has to be supervised one, not an unguarded motion, because it can result in early ligamentous failure. You have to use a hinged ROM brace that will provide mediolateral stability to the elbow, and the movement that has to be started should be active one. Only thing that can be passive is to allow passive extension under gravity. Otherwise, you have to start active motion only. Active motion on one side will help in regaining the muscle strength, and it will also keep the joint reduced because there will be uniform stress throughout the joint. Passive movements, on the other hand, cannot be controlled, and they can result in early failure of the fixation and the ligamentous repair also. So it's better to go with active motion for first 3 to 6 weeks. After 3 to 6 weeks, according to the movement that the patient has regained, you can gradually shift to the passive motion also. But for first 3 weeks at least, it should be active motion only, except for the passive extension under gravity that can be performed.